getting
Yeah, and I think to that point, that's exactly why we're talking about this subject now, because we need to understand how soon investment can be attracted to your projects. So that's why we need to, I mean, for today, what we really want to get, and we'll be around till 6, you know, make sure you have an understanding of what your classification of your product is before you leave. So try to do that, and we'll go through projects. How long do you think your presentation is, Judy?
I'm going to try to do this 15, 20 minutes, but I got to talk very fast.
So why don't we do 15 minutes, and then we'll have a short break, and then we'll come back, and I've got a list of projects, and we're gonna get comments from the workshop leaders.
Is it okay if I stand here?
Yeah, no
Thanks.
problem.
I'll lean over every once in a while, that way.
Do you want to work
Yeah,
the
why don't
slides
I
that
do
way?
it? I switch with that, yeah. I move that way.
Exactly.
Okay. And then that way you can see. Hi, everybody. Just for the purpose of moving this along, what I want to start off with is that I want to show you the comparison. This is reimbursement. That's a big, big subject. Jack talked about the FDA. That's regulatory. You go to one place, one building, you speak with the team there, and you're very focused. Reimbursement, coding agencies, federal agencies, private payers, local payers. There are so many different access points that have to be addressed, that the timeline and how those processes work together become the important key and the complexity of reimbursement, let alone the fact that you don't typically deal with this day to day. So what I want to start off with here is show you what reimbursement actually means in terms of stakeholders. Who's interested in the reimbursement question? Who's asking the question, what will happen with reimbursement? First one, the investors. They want to know, because they want to project how long will it be once you commercialize before there's reimbursement, or if there will ever be reimbursement. That's part of their idea of when they're going to invest, or when they're going to partner up with you. So they want to know that there's return on investment and what the timing will be. That's what they're thinking about. The providers, that means hospitals, physicians, surgical centers, et cetera, all the people and institutions that actually provide the care, they want to know, will this technology take care of the patient? Will they get paid for their investment, for their purchase? And will it help benefit the community that they're serving? And they want to preserve their bottom line. They don't want to lose money all the time. Sometimes they're willing to lose money, but there's something that they gain on the front end, okay? Payers and providers. Payers are insurance companies. That would include, I mean, it's a generic term. Typically, we refer to it as the private payers, like Blue Cross, United Health, Cigna, Aetna, Medicare, Medicaid. Those are the government payers. And providers, they want better patient outcomes. They want to know that the patient gets better at someone else's authority rather than just the manufacturer saying something. Okay? They want to see it happen. And patients are now back into the picture. Patients are now the consumers, and they are paying for this technology in some way out of their pocket, whether it be premiums, whether it be that they have to meet deductibles, whether they have co-pays. You are all sitting here, you have an understanding of how much money you're spending on your health care, and you're now paying for it out of pocket. So every time a new technology comes into place, that concept has to come into place as well, and those are the stakeholders. A lot of different people with a lot of different agendas. So I'm going to piggyback on what Jack was just talking about. There's different review processes for reimbursement versus FDA versus payers and providers. Whereas FDA is looking at efficacy through a PMA or a 510K process and all the different processes that Jack talked about, it's a controlled environment. Once it gets cleared or approved, it goes out of the controlled environment into the real world. And the payers and the providers, the ones who are practicing medicine, the ones who are assessing the technology, are actually saying, what happens when it goes out into the real world? Why should we pay for this? Because we don't have experience yet out of that controlled environment. So that's the first question that gets asked. What kind of experience do you have to actually prove that there will be a different or better patient outcome, hopefully better? Each payer has their own processes for determining coverage, and I'll go into coverage in just a minute, but that coverage is the access point, keep that in mind. And cost may be a consideration. So the FDA is really a controlled environment. As soon as you move into reimbursement, we are not in a controlled environment. We have all those stakeholders asking the question. And one of the things that's very important that I want to address that's not on this, that's not on this slide is the difference between a PMA and 510K for reimbursement. We're talking about the assessment. 510K means as predicate, means that there is already something out there that's being used. What does that mean? There's already reimbursement. Is that good for your product? If you want to charge more, if you want to distinguish your product from the existing products out there, what are you going to do? How are you going to deal with the fact that there's already reimbursement? You're essentially saying, me too. So how do you make the difference? Why would you, what is your value proposition with your technology if you move forward with 510K? On the other hand, if you go with a PMA, if you have a choice, because some of you may not have a choice, but if you go with a PMA, you'll have clinical data. And you'll be able to actually make a claim, and you will be able to distinguish and be able to get new codes and reimbursement and create the value proposition prior to commercialization. Big difference, big cost difference as well. So reimbursement at the very beginning needs to be right in the discussions with regulatory and clinical, just so that you know the choices. That's the whole point. You can't do anything about what the FDA says or the strategy behind it, but you have to know what you're dealing with, and you have to understand where that timeline comes in. So at the top you can see that just a little arrow of the FDA process, and on the bottom what I'm just trying to show here is how reimbursement starts at the business plan. Everybody has to be aware of reimbursement because it affects each component. And as you're going through FDA, reimbursement strategy gets developed once you understand what FDA wants. Is there clinical data that's necessary? Or do you want to plan for clinical data if there isn't? Because that affects reimbursement. It affects the decisions the payers will make. And reimbursement implementation as to how you go about actually get it starts at launch, although you're doing a lot of work beforehand, strategy, discussions, going to all those different agencies, and just understand it takes time. So who reimburses? This is just a depiction of the different types of payers. We have non-government payers on the right side, Medicare, Medicaid, government payers on the right side, Medicare, Medicaid. Commercial payers are the ones, as I said before, Aetna and insurance. The challenge with commercial payers is that they are not obligated to give us information as a public. So we have to gain information through expertise, through going through their websites as to what they can or cannot do. Relationships with payers are between the providers, between the doctors, the hospitals. It's all contractual, so it's proprietary. We don't get that information. So we use Medicare data, which is public, to help us start to establish a foundation. And so that's where we typically turn. On the left-hand side, we have integrated delivery networks, which is IDNs, and ACOs, which are accountable care organizations. Those are the new entities that healthcare reform has created and evolved, in which physicians and hospitals, those are the primary ones, actually come together, and they may actually become payers themselves. So now they're evaluating the technology as to how it affects the treatment of the patient, how it affects the marketing of their community. Do they want to bring this into the hospital? But now they hold the money, they hold the management of the healthcare dollar, and they have to also now make a decision as to whether they want to purchase this new technology and what it will do for them. So that whole area is evolving and changing right now. And by the time you're ready to commercialize, it will be pretty much in place. So the three important pieces about reimbursement is coverage, codes, and payment. That's a mantra. You should always think about that. Coverage is the most important because that creates access. Coverage is the scope of services for which a payer will pay. What does that actually mean? It means, is there clinical evidence that will demonstrate that the patient is either, that the treatment will be equivalent or that the patient will get better based on independent study. That's what they're looking at. That's what they mean by that. Has nothing to do with cost at that particular time. Coverage is about your clinical data and evidence, and that's why the decision to do clinical trial work becomes very important as you're going through your process, because that's what will be looked at. If there's no coverage, there's no access. Regardless if there is a code, as I said before, payment and coding will be the same if you're a 510K, but they may say your brand, we don't want to cover your brand, we don't want to reimburse for your brand because we don't know anything about you, we already have other brands out there, and so we won't give you access. So that becomes a decision that you have to make, and it changes with each individual product. So codes are just a language that describes the medical encounter. It helps the physician identify, put the codes on a claim form submitted to the insurance company so they know what was done and what the clinical circumstance was for it to be done. Hospitals do the same thing. I'm sure most of you have seen bills where they have all these codes on it, and that's what gets submitted. So it's really just language, but it becomes an important piece because everybody wants to have a code. It's the thing that we can all wrap our hands around and we can say, wow, if we have a code, that's a positive thing. Investors love hearing that there's a code. What they don't like hearing is what's attached to the code is the existing payment, because they want to get higher payment. They're investing money, they want to see a higher payment. So that becomes a challenge. We're going to go just a little deeper into the concept of coverage. It's evidence defines who has access to the technology. And if you get coverage, then the coding and payment will come naturally. So we always focus on what is the value proposition, where's the evidence, what are we speaking to, how are you making things different, so that we can understand, can you get coverage or how long will it take? It's generally formalized into a policy, but there are many technologies and many procedures out there that don't have policies. So it really depends. It's not one size fits all. It really depends on what your product is, what kind of patient population is out there, and if they need to develop a policy. Insurance companies don't want to develop policies. It costs them money to do that, because that means now they have to manage it. So it really depends. Usually they create policy if it's expensive, if there's controversy, if there's too many products out there that they think are fraudulent, all different types of issues like that. They will definitely develop coverage policies for any kind of product that's being implanted. That's PMA anyway. So that will definitely, that one you know has to have clinical data. It's a very time-intensive and very process-based process because, as I said, we go to Medicare, we go to the private payers, and it's a planned strategy. In terms of coding, we have to first, when you're looking at reimbursement strategy and an assessment, we look to see, are there codes that are existing? Now, codes that are already out there that are published are very specific or very broad. It can be either way. We are evolving into a movement in which codes are now being very specific, and they're bundling all sorts of services into one particular code. So it changes as the new technologies come out, or as new technology evolves into standard of care. The codes will change as well. So just as an example, if there is some type of surgical procedure, let's say a lumpectomy, and let's say there's some sort of new way to, let's say, cryosurgery to go along with the lumpectomy to make sure margins are okay, they're going to combine those two services together if it becomes a standard of care. Okay, so that changes things up. It gives you some flexibility to create a strategy when that occurs. As you, the founders of the new technologies are moving into the space, that's an area that we look for. How can we make a new code even though it's an existing technology. Because lumpectomy is a service and a procedure that's already existing. Physician Specialty Society is necessary. That's a must. If you do not have the National Medical Society community in support of your procedure, your technology, the entire environment, it will not move forward from a coding perspective. They must be involved. They must be supportive, and they can stop a technology from getting out into the marketplace or getting a new code for a number of years.
Can you talk about that for a second, about how does someone garner that support? What form does that support take? What does that start to look like for a company? Besides having a KOL speak at it, at a conference, what
kind of support it takes? Is that
yeah,
what you're
you
asking?
say physician specialty society is a necessity, but what is that actually?
Actually, it's not a besides the KOL speaking, it's actually very important, it's
Yeah.
part of your strategy.
Right.
So it's part of it's a combination of your publication strategy and your podium strategy. As you start to talk about and publish at the different conferences for the different specialty areas, actually, well, I'll go back a step, you have to understand who your specialty society is. Usually there are multiple ones. You may have the big one if you're doing imaging in some way, you may have radiology, then you have the subsets, and you may have the surgeons that get involved as well because of interventional. So first you have to identify the specialty societies. You have to understand who the key opinion leaders are, who will have influence, and what they're going to speak about. And it just basically starts to build. It's a little different story, but it is the same story as we talk about clinical evidence, because one of the reasons they hold the keys is that the clinical evidence has to show that this is worthwhile to have a code. So the society is evaluating the technology on their own to see if they want to adopt it, to see if they want to create consensus, and to see if they want to create some guidelines ultimately. It takes a while, takes a process, and it ultimately becomes part of the strategy for a code. I go to these coding meetings all the time, and I would pull an application if I get any kind of hint that my society has changed their mind or has any kind of hesitation. Application gets pulled.
So just building on this question, do the different medical societies then have specific meetings to review? Is it a formal process, I guess?
For some, it's becoming a formal process. We're probably in a transition right now. There are some societies that still hit and miss. They may or may not entertain a conversation with you. Others, it's a definite formal process that they have a committee that actually reviews the materials, and then at some point they will ask for a meeting or they'll have a phone call or something like that. So it depends on the area. As you can imagine, the surgical societies are very well, they have their systems in place. Imaging has their systems in place. The small ones are the ones the small specialties that really don't have a lot of technology, that are just moving into that space. They're still struggling to figure it out. So just to give you an idea, I just said generically there are codes. There are 4 different types of codes. And in order for you to have codes, on the left-hand side, you'll see this diagnosis codes. That's not anything in particular that you would get involved with at this point, but the diagnosis code is important to the physician and to the hospital because it defines the clinical circumstance for why the patient needed to have some type of intervention, okay, or some type of treatment. So that needs to be part of the claim. On the right-hand side are procedure and device supply codes. So there are 3 different types of codes that we get involved with. The CPT code is the most common code that most people talk about, that investors are interested in. Those CPT codes describe outpatient procedures that are performed in which the medical technology is used, and also pays for the physician work. So it's very, very important to have those codes. What's also important to those codes is that payment is attached. When a code is developed, once a CPT code is developed, then payment gets attached to it, gets assigned to it. And so the coding process is not pure, because we all know it's a bit political, because we all know that if we don't get a code, we won't be able to get payment. So the issue of getting a code is actually not only getting the code, but the next step of how we're going to get payment. Okay? The HCPCS code, HCPCS, are for those of you who are doing durable medical equipment or drugs. Those are codes that just are used to identify on the claim form that a drug, that a supply, that a DME was used. And that is not as difficult to get, although right now they are increasing the regulatory policies. The ICD-9 procedure codes are not attached to payment. They're just a coding system that the hospitals use that help them get to their DRG payment. We don't have time for me to get involved with that. For those of you who have implantable types of technologies in the hospital setting, those codes will become important. So it's just something, as a place marker to keep in mind how that would work. Just as an FYI, not only is this complicated enough, but we're going to change to ICD-10, which is a brand new system, and ICD-9 will go away, and that's supposed to happen at the end of this year. And so the point behind that I'm not sure that I was clear about is getting the code as a strategy. It's not just filling out an application. There's a lot that goes into it, and timing is really critical. And that has to do, again, with going back to where's your clearable evidence and what kind of support do you have. In terms of payment, like I said before, it won't happen without coverage. And one important key, devices are usually not paid separately. They are part of a procedure. And so you typically do not get reimbursement for the device. What you're doing is you're creating what the procedure is that the device is being used, and you're incorporating all the work and effort, supplies and equipment, whatever it might be that is used with that device to create a procedure, and that device gets slipped into that code, and the payment gets associated with the cost of the device. So it's not an individual device payment, it is a procedure payment. Site of service determines the payment method. In other words, payment is different if it's a doctor's office as to how it's calculated, how it's established. Payment is different if it's delivered in the hospital outpatient setting or an ambulatory surgical center. It's also different if it's a hospital inpatient. Where at home health is different. So all of these areas, if you're developing a device that will touch multiple sites of service as to where your technology will be used, all of those payment methods have to be brought into the assessment to determine what kind of payment to expect and what are the strategies in order to incorporate it. It takes time to get payment. I mean, that's it's based on claims data typically. There's other systems in place. Again, we don't have the time to go into it, but just understand getting new payment takes a long time. It takes a couple of years to establish any kind of new payment. So from the point of commercialization, if you're getting the new code and you're getting, which would require new payment, it could take a couple of years. So part of the strategy is how do you sell without having an adequate payment once you commercialize? You're smirking.
No, that's good.
I think the whole point of this slide, just to get through it real quick, is just the fact that because we're in this transition of healthcare reform, of changing the system, the most important piece really is that the payment models are changing. How we get paid, how providers get paid, how payers are willing to reimburse is the key critical piece right now that is transitioning. So whereas in the past we were all familiar with getting paid fee-for-service, physicians get paid every time they do a service, hospital gets paid for some type of fee-for-service plan, it's moving into a model that is more complicated. And that's what has to take into account as you think about your technology. What will happen in a number of years from now when you're ready and have to evaluate with all these different types of payment models that are coming in, how will your technology fit? If you're adding cost and the payment will only be, let's say, $1,000, or we can project it will be $1,000, and you want to charge $2,000, where's the value proposition? How can you get through that? So all of this is just moving into, they're all coming together. Important message, and I'll be finishing up here, is that the pay is reimbursed. We talk about the payers, but the reality is the providers are the ones who bear the financial risk. The payer does not, because they are the ones purchasing it. They are the ones that have to make sure that the patient has a good outcome. They have to make sure there aren't complications that cost them money to take in this new technology. And if it does, in my example, if it costs, they only get paid $1,000 and you want to charge $2,000, how are they going to make that up? What are the other advantages that your technology brings to make a hospital or a physician decide to put their hand in their wallet and purchase this? Is it more patients? Is it more marketing opportunities? Does it open up another revenue stream for them with some other diagnostic testing that's associated with your technology? Those are the things that you have to start thinking about that go again into that strategy. That's what builds the value proposition. Hospitals want to make sure their patients get better, they've reduced costs, and that they can maintain and build more patient volume. Healthcare reform is about patient volume, and that's what everybody wants in their hospitals and their integrated delivery systems. They want patient volume and want to build it as much as they can. Physicians want to make sure that they have good clinical outcomes and that they're still getting paid. And unfortunately, physicians have seen a reduction in their compensation over the past few years, and now they're going to work for hospitals. So they want to make sure that they are getting paid adequately for the work that they're putting into it. And when you bring a new technology in, is that putting them at a higher liability, or are you improving their opportunity for efficiency and reducing their liability? What are they doing? Will that help capture more patients for them and build the volume and get more payment? So those are some of the questions, but by the fact that the providers bear the financial risk, that's your value proposition. Not necessarily, you have to think about the payers, but you must never ignore what the providers, who you're selling to. And lastly, in terms of pricing, there's a difference between what the manufacturer thinks about when you're willing to set a price, when you're thinking about setting a price, versus what the provider will think about. So the manufacturer's thinking about cost of goods, product clinical development, the competitive technology prices, how big the market is. Reimbursement doesn't care how big the market is, to be honest with you. From that perspective, it doesn't matter as much. The provider is thinking about, first question, access. Is there coverage? Will they have to fight with insurance companies to get these claims paid? Is the device adding resources to the procedure or replacing a different device? What exactly are you doing? How does it affect the bottom line of the hospital? How will they evaluate? Are they giving something up, or are they adding? Just because it's nice to know, does it really matter to a hospital? Do they want to add that extra $3,000 catheter for something that they're doing? Is it good for the patients? How many devices will be purchased in order to maintain this particular service? There may be one catheter, but maybe that you develop, but 3 of them need to be used, something to that effect. The mitral clip for the heart, there are 2 or 3 clips, they have to purchase that. That costs a lot of money, and the payment for it doesn't change. So if they're adding 2 or 3 high-cost clips, then that hospital's taking a loss. So why are people buying it? So on that note, I'll just leave you in suspense, and then we can do our questions, and maybe then I can help put it into focus for you. Last thing, it's not a Hail Mary doing reimbursement. If any of you can have influence in developing with your business plan, make sure reimbursement is in every part of the conversation.
Okay, so before we take a short break, just again today, what we want to get to is for all of the teams to be able to understand what is the classification of their product, how is it regulated, and will somebody pay for it, or approximately what's your reimbursement strategy? Obviously, it's a long-term thing, as Judy says, it's a whole plan, but we just need to understand what the approximate outlook is today. So, and we'll do that by talking about specific projects when we come back in a few minutes, okay? I think the restrooms are
Sure.
that way.